webinar, which is hard to wrap my head around, but it's great to be here with all of you. This is on sustaining the family leader role, which we've had a lot of different conversations around, so it seemed very fitting to have this be one of our final webinar before the July capstone learning session. So we'll go to the next slide. All right, so I think that I will take this one on. If I think that Meg was held up. She was going to be doing this, but I think she, oh, here she is. Meg, would you like to take on the housekeeping and such?
Sure. I'm sure people are tired of hearing me talk about this, but I will go ahead and go through it anyway, just in case there's one person who says to themselves, oh, Meg didn't do the housekeeping. I'm so disappointed this webinar was a failure. So as you know, the webinar is being recorded. Please don't use your speakerphone. If you are on the phone, it gets echoey and weird. Please don't put us on hold so that we can avoid any background music. If you are on the phone, please mute when you're not speaking. This applies to your computer speakers as well. If you're not speaking, please go ahead and put yourself on mute. If you are on a handheld phone, you can press the mute button on your own keypad, or you can press *6 to mute and then *6 again to unmute. Participation is essential as always. I think we have an incredibly informative and exciting agenda for you today, and an expert panel of folks who are going to impart some wisdom to us, but we also want to learn from it with you all. Please, please don't be shy about participating either verbally or in the chat box. We'll do our best to modulate and moderate both. If you have any technical issues with Zoom or sort of any other tech issues, please shoot a chat message to Ben specifically. If you have content questions or comments, please make sure that you're addressing the whole group so that, again, we can learn from and with you. And if you would, please link your phone with your computer if you are on the phone for audio and on the computer for visual. To do this, if you join by computer after calling in via phone, you're going to want to bind your phone and your computer together so that we only see one representation for you. It makes it much easier to send people to the right breakout rooms, et cetera, and sort of just manage those logistics. You can enter your participant ID number to bind your phone and the computer session together by entering pound and then your own personal participant ID number. Don't try to type in participant ID, and then pound again on your phone. Your participant ID usually pops up for easy access on the webinar platform. You can find it under Join Audio if you don't. Let's go ahead and move to the next slide.
This one's new, Meg, so if you want me to take it, I'm happy to do that.
I was just about to say, Libby, would you talk about the live?
Yeah.
We're going to tell people the right thing. Thank you very much.
Yeah, absolutely. So for some of you, you may not be able to see the live transcript until you enable it. So what you can do, and we have it turned on already, so you go down and click live transcript and then show subtitle at the bottom of your Zoom panel. And if you have any problems with that, you can go ahead and shoot Ben a message and he can help you get that set up, but it should be relatively simple. I'll turn it back over to Bethlyn.
Yeah, I'll take it. So we like to start things out getting an opportunity to kind of get a little connected with the group. So we are hoping to hear from you. If you've had any small, we know there's some teams that we've heard from some of them, but we know that we're at this point where there's a lot going on with each team as you're looking for ways to continue the good work that you've been doing beyond the CoIIN. So any recent small wins of any sort or exciting news you'd like to share, we'd love to hear it in the chat, and folks can just take a look and see what's been coming up. I would love to see that Team Texas says something, for instance. So throw anything in there. If it turns out there's something you can't think of anything project related, just throw in something that's an exciting small win for you at this point, and exciting news you'd want to share anyways. I see that we are not feeling it in the chat right now. So we can move on if it's not just not happening for folks. So let's move on to the next slide. Oh, congratulations. And we'll just start the agenda while everyone's thinking about what that might be. Really you don't have to overthink it. For instance, I do know that Team Texas they'll be coming out with a statement and said we could share that they have a grant that they're going to be awarded to be able to build upon the CoIIN work. So that's pretty exciting, and we'll share more about that in detail once they have a press release coming out and things like that. Oh, here we go, everybody. Great. So as you can see, we're doing our little bit for framing, and then Carolyn Oshouse is going to speak to us a little about integrating partnership with family-led organizations into systems of care. It has some really important things to think about. Then we have our panel, Teams Texas, Indiana, and Alabama, and we're going to ask them some questions. And along the way, you can ask some questions as well, and Mary Jo will moderate that. And then this is an opportunity after that for the state teams. You had all done a little pre-work just to think about and wrap your heads around, like, all right, how would I articulate where we're at with what we're looking to do to sustain the family role, and anything we're grappling with, or even just small wins that you've had in that regard. It would be really helpful to share that across the groups and people to hear that. So we'll start calling out, asking teams to share when we open it up, and then we'll close out. So I'm first going to just say a few things to help us consider what we're doing today. And I want to go quick so that the panel has time to be the ones to talk. What we're considering in this case of sustaining family partnerships, I'm going to call it a few things that I would refer to as like the elephants in the room. Fundamentally, it's about partnerships with family leaders and family-led organizations, but the foundation of this does involve money. I mean, it ends up meaning that money shows the value of that partnership. So we want to understand that tension, duality, and importance of that. Funding for family organizations isn't enough to drive this, that they get independently from projects like the CoIIN project. So they need more money to be able to do that kind of engagement. And at this point, the way the system is set up, you're really limited in how that partnership gets defined by the clinical staff, the clinic, that care team, about how they consider family partnership and how they're oriented to and may want to engage. So that's in the CoIIN. We have folks that were really wanted and dug into that work, and we were blessed for that. But there is no mandate for that to continue from the grant itself. There's just this place where we're like, all right, so now what, right? So how do we help make sure this happens? And in the context of the panel, we're going to consider both the longer term system changes and incremental, practical, multimodal strategies so that you can get progress along the way and meet systems and teams and clinics where they are at, in addition to moving things forward in a larger systems level. So that's what you'll see in the panel too. We have both family leaders that are embedded in clinics and that kind of role, talking about that. And then there's also robust family partnerships with family-led organizations to consider. We asked this of the NAC. This is one last thing I'm going to say and then I hand it over. We asked them about sustaining the family leadership role. That's our National Advisory Committee. And they did talk about a few just high-level framing things as well, that the sustaining the family leader role is possible by showing the value of those roles, which is something we're really looking at how we can help you do. It can't just be about a moral argument that you should. So that was something they suggested, and that sustaining funding should not be done just in one traditional way. Got to get creative about it. How can we braid funding into other places where family leaders are doing the work? So, for instance, new funding from the home and community-based services infrastructure that is being funded through recent legislation, the American Rescue Plan. And then in policy, another idea was families must be partnered in every public program that serves kids, but it's not a requirement right now. So those were just some thoughts, teasers from the NAC as we move to the panel. So I hand it over to Mary Jo. Oh no, I'm not handing it over to Mary Jo. I'm handing it over to Carolyn. Carolyn, take it away. Sorry about that.
Thanks, Bethlyn. So in recent months, the CoIIN teams have been focusing on sustainability plans. For those of you who are also participating in the Care Coordination Academy, you know that this has really been an important and ongoing focus for that group as well. Yet we haven't really spent time talking about the sustainability of the partnerships that we have developed over these years, nor the sustainability of family-led organizations. So that's what I'd like to talk a little bit about to start us off. I've had the privilege of being involved in many grant-funded projects and programs focused on improving systems for children and youth with special health care needs for more than 32 years. I've participated in these projects in many different capacities as a parent, as a program coordinator, and now as the executive director of a nonprofit organization. These projects have taken place in collaboration with children's hospitals, pediatric clinics, state agencies, national professional associations, as well as other nonprofit organizations, and have usually focused on the acknowledgement of the need to improve all of these institutions and agencies and systems on the local, the state, and the national level. Yet I've often seen these projects struggle to be sustainable, and I wonder if that lack of sustainability sometimes lies in the inability to sustain meaningful partnerships with families and family-led organizations. Over the years, grant projects have increasingly included a commitment to, and more recently, a requirement of partnering and collaborating with parents and families and youth, along with family-led organizations. And these projects always require the participants to think about and plan for sustainability. This CoIIN project that we've all been part of under Meg's guidance, along with the great advisory committee and staff that Meg has assembled, have done a really great job of ensuring family involvement throughout this project. Families have really played an integral role in the work of each of the teams, as well as in the design of the CoIIN project overall, and how it's evolved actually over the years. As we think about sustainability, we usually end up talking about sustaining the project, the improvement, the funded entity. Yet, as I said, we fail to talk about how the partnership and collaborations between the system organizations and the family-led organizations will be able to be sustained. And we don't talk about the financial sustainability of family organizations and their important and ongoing role in the support of families in the communities where families and children live. Community and statewide family-led and staffed organizations like ours, like Family Voices of Minnesota and other Family Voices organizations and parent-to-parent organizations, have really important contributions to the medical organizations and the state agencies that are working on all of these system improvements. And we serve the same families. But yet our funding is often extremely specific, and it's often very limited. Organizations like ours work with families raising children with disabilities across the whole state, our whole state in Minnesota, and that's true of all the other organizations too. We employ experienced parents who provide support and information to other families about how to navigate these complex systems, how to work efficiently and effectively with their child's providers. And we provide emotional support so other families don't feel alone. Our parent staff know and understand how the systems really work and not how they were designed to work. Yet we struggle to find consistent funding that can provide an adequate number of hours or a living wage to our staff and allow our organization to grow. We really never know from grant period to grant period if we can maintain our staff or even keep our organization going. And yet our organizations are a bridge from the medical, social service, and school service community to the real community where children and families live and thrive. So today, I'd really like to challenge all the teams to ask yourselves, how are you going to maintain patient and family-centered care? Patient and family-centered care goes far beyond the care of the individual child, but it's really also about how patients and families are included in program and policy development, implementation, and evaluation. And it should be foundational in the work that we all do together. Family-led organizations are essential in helping other organizations and agencies understand and teach family-centered care to other families and to providers. I'd like to challenge all of you to think about how you're going to sustain these partnerships with families and family-led organizations and how you're going to help fund those partnerships. Joe Biden said something that I think is very meaningful. He said, "Don't tell me what you value. Show me your budget and I'll tell you what you value." So that's the challenge I leave you with today, but I think this is a really great opportunity to hear from our colleagues in Texas and Indiana and Alabama, who are also going to talk a little bit about their experiences around sustainability. So thanks.
Thank you, Carolyn. That was an excellent way to frame this conversation, and you just have such an eloquent way of getting right down to the most salient challenge and what we need to be focusing on. I'm going to hand it over to Mary Jo, who's going to get our panel going. Thank you to you and all the panelists.
Thank you, Bethlyn, and thank you, Carolyn, for your comments. This is a perfect opening to welcome and introduce our panel today. From Team Alabama, we have Vera Spanks and Susan Colburn. Team Indiana, Lisa Kuchera. And our Team Texas, Maureen Ben Scooter and Sherry Santa. So welcome. The way we're going to do the panel, we have several questions that we've shared with our panelists to think about and prepare their comments. We encourage your questions. They can be entered into the chat or raise your hand, and we have a couple that will follow the chat and watch for questions and help get those inserted. Based on our time, we're looking at about 6 minutes or so for each question. Of course, some will take less time, some more. So it's kind of free flowing, but encourage you, ask your questions. These are a very knowledgeable panel. So I'll jump into the first question. We're going to ask you to tell us a little bit about your team and how it's configured in your project for family partnership.
I'm happy to start with this one, if that's okay.
Thanks, Lisa.
For Team Indiana, our project was embedded in 3 medical clinics. It involved 3 primary care physicians, and then they engaged the services of 3 care coordinators who were embedded in the clinics. Those clinics are in a rural location, a semi-rural location, and one in the center of the city. So it allowed for different populations throughout the areas. Each care coordinator was charged, or each clinic was charged with identifying and enrolling 100 patients apiece. So that's the clinic end. They were then supported by at least 3 individuals who would provide support to them, answer questions, help them get set up, and that type of thing. And then the 2 family organizations were engaged to provide support then. Support as a professional training, offering the care coordinators training and parent perspective on things that mattered to the families. And then we also offered a referral process where the families could be referred for that parent-to-parent connection. We were successfully able to engage 100 patients per clinic and maintain those relationships with there and built on that as well.
And Lisa, your family partnerships, who were the organizations?
So we had both the Family to Family, Family Voices of Indiana, as well as our Parent to Parent About Special Kids were engaged. Both organizations were each had their own responsibilities within the team. And then we also, actually, we had a Title V representative in on the team as well, which helped to talk about sustainability and things that go along with that.
Thank you, Lisa.
Want me to go next?
It would be great. Thanks.
Okay. Vera and I are here for Team Alabama, and just an overview of kind of how our overall team was set up. Our large state team brought together many different partners from the 2 tertiary care centers, just many of the partners that we work with kids with complex needs. And we included a youth consultant and some of the a couple of parent consultants beside myself who work for our SHIN program. But we also included a couple of other family leaders from Family Voices of Alabama, which is our F to F, and also a family who at the time was an executive director of another family-run organization. And interestingly, over the last few years, some of the roles have changed. Vera was a parent consultant here in our SHIN program. She moved and had to give that role up, but we hired her as part of the F to F. The other parent who worked for the other family-led organization, which is called Full Life Ahead, she has come back to work for our SHIN program. She worked with us previously. So the people are the same, but the roles kind of changed. You know, our project has basically surrounded one clinical program at the University of South Alabama in Mobile. And the different activities that we have done have been focused there with their CMC clinic.
Thank you, Susan.
I can go next for Texas.
Thanks, Sharon.
Hi, I'm Sherry Santa. Sorry. As we sit here on this last webinar, I can't do this without starting with where we began. And that was with a phone call. I was the FDF coordinator at Texas Parent to Parent. And that was where I was introduced to the wonderful Meg. This was a week before we met in Chicago. We were developing our team in Texas. And I will never forget, Meg, you said that parent engagement is necessary, it's important, but you very strongly suggested that we have someone on our team that was a family representative when we got to Chicago. And I loved you from that moment. I was like, this is great, because it's truly from the top down. Family engagement and family leadership was passed down to each team, and I really appreciate that. So our team was made up of the Dell Children's Comprehensive Care Clinic, in addition to a representative from Department of State Health Services, a representative from Health and Human Services, myself as the family rep, and at the time that was Texas Parent to Parent that we were working with. And then we also had 3 people from the clinic. So the clinic and our family organization have worked together from that very first phone call and that first meeting in Chicago. And then we just developed our work as we went along. Honestly, there was a few months where I wasn't really sure where we were going because Team Texas has such a huge project, and it was hard to find exactly the place our input was needed. But over the last 3 years, we've really been able to hone in on the different strengths of our different family leaders. We know that some families leaders are really interested in a certain topic or whatever, and they were able to give feedback. And now here we are at the end of the project, and we have 9 moms that are very dedicated to the work we're doing. Even after this project ends, they're very dedicated to continuing quality improvement projects within the clinic. And I think one of the unique things that we did was we wanted to make sure that no one stayed at the like, this is just the family work group. You can move on from here. There's other things to do. And that's well represented. And Maureen now joining us on the state team also. And if we would have gotten to travel, she would have gotten to travel with us this year. And I'm very sad that we're not traveling. But for me, that shows a true progression of on local level, state level, and national level. We have been very cognizant about making sure that we move our families up into whatever roles they feel comfortable with.
There is a question.
Yeah, go ahead.
Oh, Maureen, you go first.
Oh, I can answer that question. No,
Great.
we did not, the parents, we did not know one another at all. And I would just like to add a comment as somebody who, I'm a parent leader, but I started this project as a parent of a child who attended the clinic that's involved with the project in Texas, period. I got invited to some meetings by Sherry, and I thought, well, interesting project. And I now consider myself a family leader on the team, and I will continue to be a leader in the project as it goes forward at our comprehensive care clinic. And there were a couple of pivotal moments for me in that development, and I'm just going to mention them quickly because they are representative of how I was allowed to develop as a leader. And one was when Sherry invited me, with the blessing of the rest of the teams, to start attending the big team stakeholder meetings. And I was the first parent to start attending those, who was just a parent. And then I had a meeting with our clinic director and Sherry, where they asked me, you know, what else could I do? And how else did I see myself leading? And I just went out on a limb and said, I think I could help you facilitate those stakeholder meetings. And immediately, they said, yes, great idea. And so there was the training and formation from Texas Parent to Parent, and then willingness on the part of the clinic leadership to let a parent step up and make use of all those PTA meetings that I've led over the years, and put that to good work. So just those two components were critical in my developing as a leader in this project.
Thank you, Maureen.
Quick thing on that. In that meeting, we also noticed a little gap in our parent involvement, and that was our clinic specific CoIIN meeting that met monthly. It was specifically just for the clinic staff. But in that meeting, when we were talking, it was like, wait, we should also have a family member in there. We've talked about showing your petticoats or whatever you guys were saying that day, truly opening it up and being transparent. So there wasn't a separate meeting for the clinic only. There was also a family rep in there. And I think that was an important step also in the development of this.
Thank you, Sherry. Thank you, Maureen. That the personal invitation is frequently the way engagement begins, isn't it? So at this point in your experience with the CoIIN and the initiatives, what happens to your role as the CoIIN ends? We're approaching the end of this initiative. Can you talk a little bit about your role after the CoIIN ends, or what's going to happen?
I'll jump in real quick just for our family work group. I'd like to say how we're going to continue their work with those 9 moms. Is we're going to roll it. It will no longer be called the CoIIN family work group, but it'll now just be the CCC family work group. And we have already identified other projects that they can give input on. And because we don't want to lose that momentum by even taking a month off, we want to just keep going and keep them engaged. And back to Tamara's question about whether they knew each other, they did not. And it's been very neat to see over these years the parent-to-parent connections within that small group. They are really monthly there to work and get lots of stuff done for the CoIIN, but there's been just organic, natural connections, and that's beautiful to see. I like it when things like that come together.
And I can comment for Team Indiana. Both organizations itself are going to continue to exist for the families here. But what this has really developed is a collaboration between the two organizations, and that will continue. I think having both organizations on this team has created an opportunity for us to see how we can benefit from each other and work together as a team. So I think our collaboration together will continue as a result of this project.
Thank you, Lisa. Did Team Alabama want to comment?
Okay. So all of us individually will continue in our roles. But, you know, and I guess we're going to get into this a little bit more. So Vera works for our F2F and has support to work on several different projects, but obviously the support for this project will end. And so, you know, we're trying to figure out what activities can we continue and how can we do those? And I guess that's kind of what we're really here to talk about. So Vera, do you want to add anything to that?
You know, and also my hope would be too that even if I am not the point person, I guess, that is engaging with the families that maybe you're referred, that I'll talk a little bit about more about later in another question about what that looks like. But hopes that with the partnership that's formed with our Title V program, our Children Youth Special Healthcare Need program, there with the clinic, that hopefully they can utilize some of that parent-to-parent support too that's built in there. But as far as I will continue my role with the F2F, and hopefully somehow that will cross over and continue with the CoIIN project.
I mean, oh, I'm sorry.
Go ahead.
Well, I was just going to say, I probably should have laid the groundwork by saying that Children's Rehab Service, which is our Title V program for children with special health care needs, has a very long-standing, robust family engagement program. And so we also have a very robust relationship between the F2F and that agency, and all of that will continue too.
So this is a nice segue into maybe digging a little bit deeper, the tangible elements of family partnership in your project that you think could or should continue. What pieces can you name and identify that should continue?
I'll go. One of the pieces that we are doing within the CMC clinic site there is Family Voices of Alabama. We have placed, and I'm just going to show it. Y'all, many have probably already seen it, but visuals, nice. Our care notebook, which helps to organize information for the families, but also bring it to different appointments. And so through that, when a family receives that care notebook, I receive a referral, and then I make where that was given out, and then I make a call to the family and contact them and form a partnership, find out what, you know, how are they liking the care notebook? How are they utilizing it? Are there things that they're, you know, not sure how to use? But then what are some other ways that I can help them think through what they're wanting in their life for themselves and their family, and other resources. And sometimes even things that I can take back to the clinic staff, where maybe it was, I'm having trouble getting this equipment or this referral to go through, and just really helping improve those outcomes that we know happens when there is family involvement in the whole process. We've had notebooks. We even, so I'm hoping that that will continue. We don't have anything written in a plan that says that the clinic has to continue giving us those referral forms. But that's just one tangible way I feel like that we could continue on that partnership and should.
So it sounds like you have a formal process for the referral. Can you talk a little bit about how that works?
Yes, it's just a one-page piece of paper. I won't show you one. So what happens though is Suzanne Robinson, who is the nurse coordinator in the clinic, when she gives out one of those notebooks, she fills out the form. The family signs the form saying that they are open to family partnership, and that's how. And then she emails that form to me or to Susan, and then Susan gets it to me, and that's how that starts. And then we take it from there. So.
Thanks, Vera.
One of the things we were thinking about continuing with Texas Parent to Parent is all the wonderful trainings they have, not just the parent trainings, but the professional trainings. We were hopeful that at some point we could offer maybe the serving on groups training that Texas Parent to Parent can do, or the leading by convening, but remembering that they are resources from both parent development and parent support. So we want to access both of those.
Thank you, Sharon.
And Indiana will also continue to have referrals. And the process sounds exactly the same as what Vera has indicated. Those referral processes are available to most any medical clinic in the state of Indiana. And then I would hope that they'll still continue to participate and request the professional parent to professional trainings as well that have happened throughout the CoIIN project. But we too don't have anything formal written.
Okay. And then did we get questions answered? I think so.
Yes, we have. Everyone's been adding into the chat the answers to the questions as we go.
Okay, let's look at how buy-in is approaching buy-in to sustain the activities. What data or information do you need in order to convey the impact and the value of these partnerships and relationships? And how are you approaching that buy-in?
So our organization or our team created surveys to send to the families who are participating in the project. And that allowed for quite a bit of data as far as satisfaction and that type of thing. And that's specific to the representatives in the CoIIN team. Our parent to parent, the organization I'm with, we do monthly surveys. And the one thing that we bring to the table and that has been discussed is when you look at the parent to parent, you ask a parent, how important was it that the person you were speaking with is also a parent of a child with a medical condition? Those are always in the 90, 97, 98 percentile. And I think that can't be second guessed on any of the work that we're doing here on that connection that can happen, because conversations can be very different between medical professionals and professionals in general and a parent, and what a parent to a parent can discuss. So I think all that data to show not only are we looking at what medical conditions have been changed, what kind of services were they able to engage in, those are all things that we can definitely, those are hardcore changes. Those are things that we can say, yes, they're getting incontinence supplies, yes, they're not on the family support waiver, yes, they're getting these types of services, or they understand that. But that's not the kind of thing that always makes the biggest piece. Sometimes it is just that connection because of the isolation and the loneliness that comes along with it. And that's without COVID. COVID, I think just about everybody's felt a little bit of that, no matter what your life circumstances.
Sorry, go ahead.
Go ahead, Maureen. Thank you.
Yeah, in Texas, one of the pieces that's moving forward is a pilot project involving clinic visits, and we're doing a lot. We're measuring outcomes, studying the process as we move forward. And one of the outcome measures, and all of the outcome measures, many of the outcome measures were actually written by our parent work group. So we came up with them, and one of them is specifically, would you like a referral to a parent support organization? So it's written into the next, or at least participation referrals are written into the next step of our project. If we're going to talk about the funding, that's a different question. I'm not aware of that.
Of specifically approaching any funders with the data?
Well, of having some monetary contract with the parent-to-parent organization about we send you X number of referrals, or sort of a thing.
Thanks, Maureen.
Mary Jo, do you mind if I ask a follow-up question on that? Because I feel like we've been in the midst of trying to understand this. And I'd love anyone's thoughts on.
Right. Yes.
When you think about the kind of data, like things that I call it data because I feel like in quotes, because I feel like a lot of what we're trying to get at is very personal impacts. So how do you quantify that? How do you capture that? How do you share that out? And we've been talking about different ways to try to do that. And I'm just wondering, I heard, Lisa, that you have surveys, but I'm wondering what you feel like if you feel like there are things that you need or you're hearing that people want to be able to see in order to be able to help articulate that value or be able to ensure that that is understood. I'm just curious about what occurs to you when I ask just what's missing that you feel like needs to be conveyed, essentially, and that everyone here could help consider as we're in the final stages of the CoIIN.
So I think what was heard, the family focus groups, in my opinion, I thought revealed a lot of information as well. I didn't bring that up before, but those were an important part of what happened because it took out that professional piece, right? It was the family having conversation with the families, a family representative having conversations with the families, and they could identify through that. We were able to identify some of the things that they felt were happening. And I think that allowed us as a group to grow. There was information that came from that altered the way that we were doing things a little bit. Everything along the way has been tweaked and changed. So I think that was an opportunity to really get the voice of the family who was receiving the services and involved in the program to then provide for some change and ideas. And I think through those family focus groups, we also identified how important it was to the families to connect with each other, to connect with other families. And our current situation in trying to create is the parent cafe and ramping that up for these clinics as well, and seeing if that parent cafe can't be another way to allow the families in a safe space to share and grow and get them a little bit more sustainable on their own. And from there, we can hope that we're going to develop family leaders, because I think we had a conversation the other day about, there's some of us that have been in the area a long time. And at some point, maybe we don't have the most fresh ideas, or maybe we're going to be retiring or moving on. And we need to be modeling and crafting those people to come up and follow up in the next stage. Is that what you were looking for, Bethlehem?
I think that was a great response. I was looking for whatever occurred. And Tricia says that parent cafe sounds very welcoming.
And things like the parent cafe, will that be able to continue?
I think if the opportunity is there to build on the parents involved in the group and allow them to be their own leaders, it can. We don't have funding set aside for that for the current family leaders to work through it. I know Lorena and Natasha are on this call, and I don't know if they want to add anything specifically to the parent cafe aspect and the funding that would be necessary to follow through with that.
I can add just a little bit. As far as funding goes, we're always looking for more funding, of course, to fulfill that aspect of the parent cafe. We're currently still in piloting stages, and I think thinking through what that proposal would look like as far as in partnership with the family leaders and getting others trained in the model to move that forward. It's an ongoing discussion for sure.
Any other comments on maybe what's necessary for buy-in? Okay, let's move on to what do you think needs to happen for it to be different longer term beyond more grants? For instance, policies that could be developed at the local, state, or national level that would codify family partnership as integrated to the system. What needs to be different to establish this longer term?
So I have to say, for us in Indiana, we have a great relationship with Title V, and we've been able to secure funding through them for many years. But we've also, as an organization, have identified that we have to diversify that income to be able to sustain. So one of the things I would love to see is to somehow figure out how the medical clinics and broadly children's hospitals and whatnot within the state identify how they can help sustain these organizations and recognize the partnership that can be developed between the medical clinics, the hospitals, and the family orgs. I mean, as a parent to parent in our state, we do a lot of work with several clinics, lots of clinics, including care conferencing and things like that. But at some point, I think someone already mentioned right here that at some point we don't have the funding to bring enough people on to serve enough of those committees, to serve enough of the families that would be coming in. It's just a fact of life. We have to have the funding in order to be able to provide the service. And at some point we've got to help these clinics identify, or not just clinics, but hospital systems even, to identify the importance and see how it can be an integral part of their whole entire organization.
Jennifer, I see that you added something in the comments or in the chat box. Would you like to share that? I see you need to leave pretty soon, so give you that opportunity. And then Judith, I see your hand up, maybe after Jennifer.
Thank you for letting me listen to you folks today. I've learned a lot. My question is this. Basically, I'm hearing the recurrent theme of we need to find funding. That's a lot of the world these days. But it appears to me that in children's hospitals, even if you're a children's hospital within an adult hospital, patient and family experience scores and the lengths of stay of children are things that the hospitals follow carefully. And for every engaged, informed parent I've ever worked with, I could see the parent say, I need to get out of here. I can do all this at home. The lengths of stay are shorter. The patient family experiences are better when the parents are an integral part of the team and are well respected and listened to. So it feels like to me that what you're doing could be pitched to the children's hospital to say, look what we have done. Look what not just the complex care clinic, but the cystic fibrosis clinic and the sickle cell disease clinic and all these other clinics. Look at what we can do and what impact we can have. And don't you want to fund us? I mean, I think that's just worth talking about because everyone is measuring patient family experience scores.
Thank you, Jennifer. Judith? Just like to mention, when we did the feasibility study years and years ago of the medical home, the components of that medical home were identifying the group of kids, providing a care coordinator, nurse practitioner, keeping a individualized health plan, and a family consultant. The family consultant to that medical home was a key component of how the medical home worked. And Linda Freeman was our Uber one, and then we had ones in each one. And I just think it would be valuable to start talking with Medicaid and the funders, and I just identify this and say this is just as key of a component as the physician, as the nurse, and needs to be in the funding formula, because people are looking at coordination of care, and just name it. It's not an extra, it's an essential component.
I'll agree with that. And we have been able to secure funding from all 4 of the MCEs here in Indiana to do exactly that. We support the MCOs and the work that they do, and they send the referrals in so that we can work directly with the families on that perspective. So that has definitely been exposed. I would love to be able to see that expand into the private healthcare industry as well. But for now, we're working on those that might not be connected, as well as others.
I think on an advocacy level, anyone that can advocate for increasing the funding for the family-to-family health information centers, we know that there is funding there, but it's the same amount for each state, no matter how big you are. So some states can cover more with their funding than others, and so if you're able to join in that advocacy along with Family Voices, that would be helpful to every F2F in the country.
Lisa, this is Maureen. Can you clarify a point for me that I may have misunderstood? Did you say that your family-to-family organization has a direct contract with a Medicaid managed care organization in your state?
Lisa, that's for you, I think.
Yes, I couldn't find my unmute button.
Oh.
Yes, about special kids. So it's Indiana's parent to parent. We've secured contracts with all 4 of the managed care organizations, obviously outside of the CoIIN, but those are things that we've had in place now for at least 14 years that I know of.
This is Christine from Indiana, and I've deferred to Lisa. She's been doing an excellent job explaining the family role, and I represent the other family org for Indiana. And just to clarify, our F2F is not affiliate. We are not the same as ASK. So Lisa represents the parent to parent, and Family Voices Indiana represents the F2F on this project. So specifically, as you're talking about funding, the F2F is not in partnership with Medicaid in the same way that Lisa's describing.
Thank you.
Thank you.
Carolyn has her hand raised, and then I do want to just point out that Steve kind of seconded the idea of taking the angle of medical homes and considering that, since that's key. And Steve, you may have more to say after Carolyn speaks, but let's go, Carolyn.
Thanks. You know, one of the things that I'm wondering about that I haven't really heard anybody talk about yet is the fact that how are family organizations viewed by medical clinics and hospital systems? Do you view us as part of the system? Are we viewed as colleagues in the system? I don't know that that is the case.
I think that's a great point. I don't know what, I'm sure that, I mean, here we know we're preaching to the choir, and I'm sure there are other experiences with that. I'd love any other thoughts on that? It's a good question.
Well, this is Rhonda. Looking at the comment that Steve Fitton put in, you know, it kind of, I would agree. health systems are like, will give, I hate to say it, but lip service. Well, we need family organizations, but when it comes to actually providing any support, that's not considered their role. And I think getting past that is important, but I don't know how.
Yeah, what's needed to get past, and that we're sort of talking about the allies, right? What can allies do to help make this happen, and who are our allies that will join in the work that needs to take place to achieve the goal of sustaining the work?
I'll just comment, Tammy out in Oregon, I'll just comment to the question, how are family organizations perceived? Carolyn's question. I think they're big institutions, right? So in my experience, we've learned that some departments within the hospital system are super engaged. In our nephrology, for example, there's a tight relationship between Kidney Kids and the clinical side. Not so much in some of the other areas. So I don't know that there is an overall answer, but it's definitely worth working toward to build that trust, and it's an ongoing process.
I see, I want to say one thing, and Eileen said something in the chat. I know some of you may know that I previously worked in the world of spinal cord injury.
I'm gonna jump in now.
Oh, go ahead, Steve. Steve,
Area of Michigan right now. So can you hear me?
Yes.
Yes, okay. You were stopped for a second, but you seem to be better now. Go ahead.
Okay, well, let me take a shot at this. I mean, basically the point I'm trying to make is that if the family role can be institutionalized within the payer system as a part of what's viewed as the configuration or the the combination of services that are important in building a health home, which has a complete or comprehensive response to the child and families, then you have a much more stable funding stream rather than trying to maintain grants, because grants, most people think of grants as startup, and I think a lot of the grant funders are think of it as starting it up. And really the alignment, as people were talking with children's hospitals and the different clinical.
He seems to have frozen up, huh?
Did we lose Stephen? Yes.
Yeah.
Here, like is envisioned.
Okay.
The wonders of virtual meetings. All right, we'll hope we get him back in a moment. Oh.
Is that better?
It is a little better.
Yes, it is.
Okay, well, now I'm by a window. Maybe that'll work. Anyway, the point is, I mean, if you're in a children's hospital, they would have different services, comprehensive services that the parent role could be made a part of, and then it's negotiating with the payers to recognize it on an ongoing basis. So at any rate, it seems to me that beats a grant process, which is, tends to be unstable.
Steve, can you speak to it all? There's some chat. Excellent point, that's by Barbara Katz, and then seconded around equity. Is that, that's such a catchphrase right now. And I'm just wondering how, if there's a lever point for that right now in state policy or federal policy, places where we could latch into that, because how do you do equity without lived experience?
Without what?
Lived experience.
Oh, well, I guess I think that the service system, if the service system is really oriented to meeting needs and to being, to identifying and measuring social determinants and issues like that, it seems to me that there's a certain element of equity that then is realized.
Oh. Sadly, we lost him altogether. Meg, do you want to mention?
More vulnerable and higher need population video.
Okay. So we'll have to move on. I saw Meg mentioned bundled payment.
All right, so
Steve, it's still not working. We're gonna have to let you be for right now. So Jill, I saw you had your hand raised. I don't know if you're
Oh, hi. Yeah, it just was just a reflection on a shift in culture, and just one way that's a long term, not a short term. Although I like the whole conversation around making lived experience connections in just that navigating part for if it becomes seen as part of the system, then it's much easier to justify funding for the clinics and the systems themselves. I know in Rhode Island, they were part of a pilot project. Their F2F was part of a pilot project where the clinics all fed into a pool, and they'd had 2 family navigators who rotated throughout the clinics and the hospitals and the ER rooms to provide support around family navigation within those systems. I don't know if they're still doing it. I think so. But it started with a federal pilot project several years ago. I think, but also I think the LEND model of providing family input to pediatricians and as they're a part of the project and other medical staff, if it took it one step farther than just a reflection with families so that they get that perspective, if it is taught as this is a necessary part of navigation within the how the educational piece for physicians as they learn, then it becomes a part of the culture, and that it isn't just a touch point. Oh yeah, that's nice. Oh, I didn't think about it that way. It's like, okay, having this as a part of my practice makes my practice better.
Great. Thank you, Jill. I think that's a great point that actually there's some chat you might not be able to see depending, I think, if you're on your phone. Kara mentioned, and Eileen Florence, that I think she had to go and mention it previously, that there's a community health worker. There's some that are licensed, certified as community health workers, and that ties in. Yeah, and we can definitely follow up with that. It's actually something that our center, that we're the larger Center for Innovation in Social Work and Health, does a lot of work with community health workers. I don't know if anyone wants to comment on that. And then Meg dropped in the Rhode Island programs, the Pediatric Practice Enhancement Program, and linked to it. Kara, is there anything else you'd say about that, how they did that, community health workers, or something that would be helpful for people to know?
I was just chatting to Barb, going to chat to Barb that, you know, the PATH, which is in Connecticut, which is the P2P, the parent to parent, and the family to family health information center, all of their staff are certified community health workers because of this sort of interaction with often the case managers and care coordinators would call the family to family and the parent to parent and say, hey, help, with this part of the care coordination and other stuff. But the family-led organization wouldn't be paid for that type of assistance. And so they attempted to get paid and went to Medicaid saying, we're already doing this work. And Medicaid said, yeah, but you're not certified. You don't have the right qualifications. And so they went around trying to figure out what are the qualifications. One key in Connecticut too, though, is that there was legislation that assisted to allow, that community, broaden who could be community health workers and allow for the certification, which cost a lot of money and was very difficult for that nonprofit to do, but they have done. And so I think it's something that I know Family Voices National is involved in, as this Community Health Worker Alliance. And NANFI is leading that charge. And now in my role as Director of Policy, I think I'm kind of pulling forth, that information for us to figure out how to get a hold of, because that is something really sexy right now. It's in a lot of the Biden proposals and, a lot of discussion of social determinants or social risk factors and, funneling to community health workers. But there's sort of the concern that maybe family leaders aren't viewed as community health workers, whether they're certified or not. And does every community health worker have a certification? And, there's a lot swirling around and a lot of potential money and support going for that. So we want to make sure that, that we are included in those conversations, whether or not we're actually providing that, depending on what service is being provided. So more to come, but more ensuring, just another example that we are public health workers in different ways, in different types of family-leds. Of course, it varies state to state, but there's a lot of potential there.
And Lisa, the model that you mentioned, the agreements with the MCOs, was there any type of certification involved in that for the?
No. It's actually run under their community partnership line item. Although we have spent a lot of time, not super recent, but we've spent some time looking at what it would take to get the community healthcare certification. We did, and I do believe at the time it was a cost prohibitive for the organization at that time. And now I don't know that we have looked into it real recently.
Bethlen, I think we're at time on our panel piece, so maybe transitioning into hearing from the state teams, but I did want to thank all of our panelists for the time and commitment and sharing with us today. This was very, very informative and helpful. And so I'll turn it over to you, Bethlen, for this next section.
Sure. I think, thank you, everybody. I think we really got into some robust discussion. I was even trying to make sure I followed the chat. I want to make sure, I don't know, first off, if there are any just other, what we're going to try to do is give a chance for each team to share a little about what they got going on, and can see how far we can get in having those conversations. I think regardless, it's helpful for everyone to hear what others are doing and kind of crowdsourcing what are some little innovations or big innovations going on that could help each of us. So first off, any other thoughts tagging off of this conversation that we've just been having, and we can continue on with this as we're having this portion of the discussion. Just wanted to make sure we caught whatever people wanted to say, and if I missed something in the chat, I apologize. Feel free to.
Can I just say one other just little thought? And we really talked about all this, but all of these pieces are what's important. We know that Title V has decades long commitment to family engagement and family partnerships, and I think most states have some form of that, and it's not perfect, but it's taken time to build that. And so so that's one piece. The family-led organizations are another piece, and then engaging these other entities that we've talked about today, that would be a way to help it grow. And I don't know, I just had that thought that we need all those pieces together. So
yeah, it's not an and or, it's a moving forward and continuing with everything, and letting it And it also allows you to meet wherever each state is at. With one thing we've learned from the CoIIN is that everyone's in a different place. We all need to let our petticoats show to be able to move forward. That is distinctly a Meg saying that we all have taken on. Thank you, Susan. That's a really good point. So we'll obviously share more around this community health worker. It sounds like there's a lot of interest in that. I'd love to hear whatever team feels like they want to go first and just that share kind of what you're thinking, where you're at with the sustaining the family role, anything you're grappling with, or even just little small innovations and wins that you've had along the way for the group. And we can kind of talk it through with you a little bit and kind of get a few out there to consider together.
So this is Jill, and sorry, I'm now in the process of driving, so if it sounds a little weird, that's why. But I think kind of, and Cindy and Shonda can also chime into this. I think one of the things we looked at long term, as far as the F2F was in the process of the CoIIN. So we had a bit of a unique team when we, for the CoIIN, in that we were a part of every level of just kind of developing the process, developing the intervention, and then being a part of it as integrally as Seattle Children's was when we worked with our NICU families. And I think for us, this was looking at, because there wasn't funding moving forward for the program the way the program is, that we looked as F2F how to integrate the CoIIN method, the roadmap method that was developed into some of the other blended projects that we have. How did it fit with some of the work we're doing in other avenues, and have found that there is a great amount of potential to create just kind of a model of care coordination where we connect with other systems. And we also, through this and through Seattle Children's commitment to keeping just bits and pieces, or as much as they could, of that community care coordination for those families, and have been able to move it into another project, that person who is someone we've already been working with, that the team is looking at just kind of a direct referral process to Cindy and Shonda, because they're known by the team, because they're known as a part of that process. It made it easy to create that pathway. So, well, easier. Yeah. So we now have, we've never had a direct referral process for any medical system in the state. And so we're really excited, and we really hope that long-term it creates a model for other NICUs where we can be that catchment for if they don't have any family direct support connection, or if they are working with other family organizations and there are families that don't fit into those catchment areas, that then they know that they can connect with Cindy and Shonda. So we're really excited about that new thing that's walking through the door.
That's very cool. And it's similar to, we've heard a few other really the operationalization of that referral process so that it becomes an actual tangible pathway, and that's happening in some cases. Jill, is there anything that you're grappling with that you'd want to ask the group at this time? You don't have to have anything that comes to mind. I just thought we'd take that opportunity.
I think the grapple is that, and I think we're kind of addressing it as the team, the whole state team is really looking at ways to, like you said, operationalize just the care coordination out and beyond children's, even out and beyond a medical setting. What are components of the roadmap process and the linkages with peer support that fit in other avenues, like our child welfare system and foster care, or like the community health workers? How do we pull some of those components into the work that they're doing and bring children into that, and it's not just elder care in our state? Or how do we embed within community health centers a pathway for that support? So those are kind of the things that we are grappling with, how to present it, how to make a thought point for people as they're developing their work.
Yeah, so you're really looking at the community and all the different, the context of the whole person and all the different access points. Feels like no wrong door in a way, and ensuring that you're, any thoughts on that? I don't know if we may or may not have experience that will be relevant and pertinent. It could just be a grappling that you're also having. Okay. So who, what team would like to share next about where they're at and where they're trying to get to?
I can go for Team Massachusetts. It's Elizabeth.
Yeah. Hi, Elizabeth.
Hello. So right now we have a family advisory council for complex care service. But what we are working on doing is integrating the work that we've done here at CoIIN even further into that role, and really giving them, more opportunities to work with CCS just in general. Because right now it's very minimal hours, so we're trying to see how we can ramp that up. So right now we're working with like the Department of Patient Experience at the hospital, Family Voices, the Federation here in Boston, and the Department of Public Health, about how to go about doing that and how would that look to be the best. And as part of that, how can we even expand from there to work with the primary care groups, which we call Rainbow and CASA, how to expand that to make a very comprehensive family leader group, basically, as our center grows and we start collaborating more with these different groups. So really, at this point, it's kind of a logistics thing, in just terms of how we want that to look. What's the best way to go about incorporating all that we want to incorporate, and then obviously funding is a big thing. But yeah.
So it sounds like you feel like you've got some buy-in around the idea, and you're talking to different stakeholders,
Mm-hmm.
and getting the where have you gotten with that as far as, because sometimes the devil's in the details. So with with those pieces, how is that, where have you gotten to, or what's the next thing that needs to be figured out in relation to funding? Like what's that conversation looks like, if you don't mind sharing, just that might be useful for folks to hear.
Yeah, the first thing we did was get buy-in from the different groups. So we got buy-in from Department of Patient Experience, and then like especially with the primary care group, getting the buy-in from the director of primary care. If Judy unfortunately had to leave, so she kind of knows the details a bit better than I do. But I do know they're like working to see what kind of either funding is available in the department, or if there's anything on like the DPH side that we could use. So at this point, it's just kind of a matter of, all right, what kind of budget can we make and where can we find this money? And then with the budget, how can we move forward? Pretty much. Yeah.
I appreciate you're doing the best to answer that as you could.
Yeah, I'm definitely not a financial person or anything. So.
I hear you saying you're looking for where are those line items that kind of already exist that this could almost be a reallocation and pull from to be able to keep this in the operations and integrate it.
Yeah.
Yeah. And from talking with folks like Team Colorado has mentioned in the past, that when you put in just dollar amounts, when you really look at it, if you're talking about advisors, it's not a lot, particularly for a large hospital system. It's not a ton of money. And while they don't have a ton, once there's the value that goes along with that aligns to their goals and the patient experience benchmarks, et cetera, you could really make a case.
Mm-hmm.
We have time for one more group to go, and then we're going to have to, we'll do a very quick wrap up.
I can do a super quick report for Wisconsin.
We'd love it.
Super quick. We're moving forward with actually having some more family focus groups and facilitated by family members who have kids in the CMC programs. And so we're really excited about that. And then the other thing is that we have applied for 3 grants, 2 of which we did not get, 1 of which is still pending. So, but our team is kept intact for all of that, including the family representatives. And so I think our team feels very strongly with however this work moves forward, is that it's just like not a question that family partners are integrated as true partners in this work. And so I just also need to echo what Ivy said about sort of the top-down direction from both HRSA and our project leaders around the integration of family representatives as partners in this project is huge. And look forward to more of these opportunities in the future. So, and then my last thing that I'll say, sorry, the last was supposed to be the last, but it's not. Anyway, the last is that as the complex care programs are also doing other research projects and other work, they have infused family representatives and the family to family, us, in a lot of those projects too. So this has spawned other partnership work. So that's pretty exciting also.
That's, I've heard before. So we were saying earlier, that's such a great way to kind of wrap up and say healthcare teams or those doing that care provision. We were saying we started with, we're at the way it's set up right now, they have to see the value. And I think sometimes that is the seed money. The seed money here was to be able to help say, oh, I see, like the value is very clear now. And so we want to continue it, and being able to help see that spread within the system and have that be a way to make sure that it's experienced, even if there is potentially initial hesitancy. So I think that's so, it's amazing to hear. I mean, there's so much more to do, but to recognize what we've been able to do, what you've been able to do, and to also say, I myself am an ally. I do not have a child with medical complexity. We have a leader on this project. It cannot go unnoticed that Meg Camo is a parent. And while that was not her primary role, that no doubt made this work the way that it did as far as that leadership, and made the honor mine to be able to be a part of it. But it needs to be a non-negotiable. And I think that that's an important thing for all of us as allies to understand as well, and to help and advocate for. Thank you. This is not the end of this conversation either. We're going to do some more talking and planning to help ensure that we continue to provide some robust technical assistance and support through until and into the learning session. So please share our thoughts about how we could continue to address this. So let's go to our wrap up. And thank you again to everyone that contributed today. This was an excellent conversation. We appreciate it. So just like to return to every time what our upcoming deliverables are and due dates. So we have drafts of things that we can help support and provide assistance. Want to really make sure everyone recognizes it's just a chance to make sure you're getting everything down for the state team chapter, including the impact statement, for us to be able to help give some support and ideas around that from our perspective, because we are external to your core team. And then if you are doing a focus group or FESAT or any other kind of wrap up activity around that, you'll want to try to consider doing that within June or July. We gave it a list of options. So the focus group and FESAT are optional, but we thought it would make sense given the import of those activities for this project and the way they were so foundational to find a way to return and wrap that up within your own teams as that's meaningful. And then in July, on July 30th, the finalized state team chapter, including the impact statement, is due at the end of year 4. So next steps, if you can complete the evaluation, we really do read every single one and consider how we can address every single comment. Continue to work with your team as you're looking at these plans and your action steps with partnerships. Obviously, you're going to be doing that. And then we have our July virtual learning session as our final capstone event. So make sure that in that evaluation or via email or anywhere, coaches, whoever, just let us know what you're thinking for what you'd like that to look like. And we're thinking about it too. And then there is family focus group infographics are now final from the first round, that like full network level analysis we did, and they're beautiful and they're available to you by the link right there. And we're going to send those out. And please reach out with any questions that you may have. So we were very excited. I have to give a big shout out to Jessica Flaherty, and because she led the process for those, and Kara and Mary Jo took a really close look at them to ensure that we were really aligning to what we want to make sure we're conveying in those. So it was just excellent all around. And here's the evaluation. So thank you, everybody. We are ending at 3:30 today, Eastern time. Well done. And it was really excellent to be with you. And again, appreciate the time, energy, dedication, and partnership with everybody. Meg, do you want to say anything before we go?
I'm actually not sure I can talk right now. Thank you.
Yeah, I teared up at some point too. I have to say. Thank you, everybody.
Thank you.
Be well.